Thanks, Dave. Good afternoon, everybody. Well, I watched the master this morning dancing on stage, apologizing to a customer and winning him back. It was unbelievable. So lower your expectations for my presentation here today. I am a little bit daunted by the fact that the topic here is the future of healthcare, and I've got about 10-15 minutes to cover it. I don't know what I'll do with all the extra time. But let me tell you in essence what I'm going to say to you today with a couple of examples. That no industry other than technology is facing more change more rapidly than the healthcare industry. Now, many of you may say it's about time. A lot of us inside the industry think it's about time. But how that change develops and plays out is going to affect every one of you and every one of your family members and friends. It's an incredibly important debate. I would argue that we are at an inflection point unlike any other in the history of the healthcare industry. In the 1960s, the big changes were the implementation of the Medicare program, covering people 65 and older. The Medicaid program, a shared state and federal program to cover the poor. In the 1970s saw the great increase in private health insurance, but costs went through the roof. In fact, when I cut my teeth as a junior health administrator, when we sent Blue Cross a bill for $100, they wrote you a check for $100. What a concept. That's long, long gone. Healthcare costs went through the roof. That's when GM said they put more into healthcare costs than they put into steel in the cars. I was never sure if that was a statement about healthcare cost or the quality of the cars they produced, but whatever. That was an issue. The 1980s saw managed care come in, and patients didn't like it. They wanted choice. They wanted to be able to see the physician they wanted to see. The 1990s saw an incredible economic boom, and while there was pressure to do things in healthcare, and President Clinton certainly tried, nothing much happened. Healthcare costs continued to grow. And in the first decade of this millennium, the big change was the offering of health insurance with very large deductibles, very limited benefits plans, and that has kind of run its course. And I would argue, and my point today is, we are at a whole different era starting right now in the healthcare industry. Now, how does this affect you? We need people outside the healthcare industry to be involved in thinking through how we deliver care in the coming decades in this country. It's a huge task, but it affects everyone. And I think we've shown well enough in the healthcare industry. There's some things we do well and a lot of things we don't do so well. So let's see if we can move this ahead here. I'm going to spare you a little more of the PR about UCSF. I thought Mark handled it pretty well. You know, in fact, I have to tell you how the $100 million naming gift came for the UCSF Benioff Children's Hospital. Mark and Lynn had been very supportive of the hospital project, and I asked Mark if he would consider going out on a sales call or two with me to talk to potential donors. Mark said, sure, I'll go with you. So we went out, and you can tell what it would be like sitting with Mark. I kind of kicked off the topic of what we were trying to do. Mark took over. Said, let me tell you, this is the greatest place. It's the future of medicine. It's on and on and on. And by the end of 2 or 3 of these sessions, Mark had sold himself, and he and Lynn made the decision to go ahead and name the Benioff Children's Hospital. Anybody else want to take me out on some fundraising calls? So you've heard, this is a big deal place, but the main thing I will say about UCSF, and the reason that it is as prominent and had the kind of attention that Mark gave it, is because it has harbored many unusual thinkers. And you're going to hear from far more unusual people than me, after me in this track today, far more interesting people who will talk about specifics in medicine and in healthcare. But I think that the history of UCSF is looking for people who are willing to look at issues differently. So when Creutzfeldt-Jakob's disease was being reviewed, mad cow disease, and the entire belief in healthcare, in medicine, was that this was caused by an infectious agent of some sort. It was Stan Prusner who said, no, it's a protein. Nobody thought a protein could cause a disease like that. He proved it and won a Nobel Prize for it. He was willing to buck the tide. And that, again, is what we're going to need in healthcare for everybody to get involved if we're going to make the changes we want to make. Now, here's my premise, and I'll go through this quickly. This is a huge industry. 1 out of every $6 in the nation goes to healthcare. It may be one of the biggest employers in every congressional district in the country. It is complex. If you don't believe me, look at a healthcare bill. You know, who can understand a bill? But just imagine the complexity of getting a drug to a patient in a hospital, and especially when a patient is on 10 or 15 different drugs going in, and managing all that. Very, very complicated. It is intensely personal. Hospitals and doctors are the people you're working with when a child is born, when a patient is given a cancer diagnosis, when death occurs. These are very special moments in people's lives, and so it is not something that can be relegated to an impersonal process. It's expected to be, in some people's minds, a public good that everybody gets as much health care as they want or need. On the other hand, we're supposed to run like a business. I don't know how many of you read the Wall Street Journal this morning. Front page. It's talking about intensity modulated radiation therapy for prostate cancer, a device to kill cancer, lift revenue. So this really states it right here. This is about, is it about helping cure disease, or is it about, and the premise of this article is, this is a way to make money in the business. Healthcare is very different on where you live and who you receive your care from. If you're in a rural community, you may not be offered nearly as many options as if you're in a urban community. However, maybe if you're in a community that has a lot of specialists, this is the work of the Dartmouth Atlas, that they'll argue that in fact you'll get overtreated, which may be just as bad. And part of the fact of healthcare is we don't have all the data to know whether you're always being undertreated or overtreated. It's an incredibly labor and capital intensive business. In fact, we pay a starting nurse, well, let me ask you, how much do you think we pay a starting nurse to work at UCSF Medical Center? $95,000. It's about $110,000 a starting nurse. Now, when you're in a hospital, you'd like to have a nurse pretty much around the clock. And you can start to imagine how that drives up cost, but it's really a critical part of the healthcare industry. Our delivery model is based on a decades-old system. You have an office visit. You need to see the doctor, call up the doctor, call up, set an appointment. Can't do it here or there, you schedule time. And oftentimes, you are putting an enormous amount of time and energy into a very brief encounter to gain the intellectual capacity of that physician. And costs are growing at an unsustainable rate. We've been saying this since healthcare was about 10% of the GDP. It's now about 17%. Economists say at 25% it really is unsustainable. We're on our way there, one way or the other. And so here's my takeaway from this. This is an industry that needs disruptive innovation unlike any other industry. We need the Ruby on rails. How's that? Pretty good? I don't know. I don't know how disruptive Ruby on rails is. I don't even know what it is. Sounds good. But we need it. We need to think differently about how we deliver health care. Maybe we don't need everybody insured. We just need to figure out how to get people the care they need when they need it. We need innovative thinkers like Stan Prusner, like people you hear this afternoon, but people outside of our industry to weigh in on ways that we can rethink some of the big issues. And I'll talk about a few of those in a minute. We need to leverage technology in new ways. I'll talk about how some of that's being done. But again, this is where you could maybe in particular help us think through different ways of delivering health care. And thinking to Jim Collins' book, Good to Great, he talks about the tyranny of the or, that we don't want to say it's either better quality health care or higher cost, or lower cost, but you can't have lower cost if you're going to improve the quality of health care, that we need to find the power of the and. We're going to increase the quality of care. We're going to provide more care, and we're going to lower cost at the same time. That's the kind of disruption that we need. We have not had, but that is really our challenge in the healthcare industry. So we need unusual thinkers, and I hope that will include all of you. Now, I'm going to talk today about 3 different areas, 3 different domains where I think there's some important work to be done: science, policy, and people. And let me first talk about science. A lot of the science you think about is the science of discovery. So I just pulled off the UCSF news release today. Listen to this. UCSF team develops logic gates to program bacteria as computers. A team of UCSF researchers has engineered E. coli. You thought E. coli was bad. Here we go. E. coli with the key molecular circuitry that will enable genetic engineers to program cells to communicate and perform computations. That is the science of discovery. It's an incredible advance. But there is also the science of integration. How do we take that discovery and link it with the work of the other people you're going to hear today? How do we take the science of application, of taking what we learn and applying it more broadly? So you'll see one of the main questions we have at UCSF oftentimes aren't about new scientific innovations. We have a lot of those, new discoveries. But how do we deal with some simple things? I'll mention hand hygiene. This is probably the single biggest cause of death in hospitals in the country. It's estimated 90,000 people die each year in hospitals because of infections as a result of lack of hand washing by providers. Wow, 90,000. So we know what the answer is. Wash your hands or use a gel going in and going out of a patient room. But we need to think, we need unusual thinkers to help us make it something that everybody does every time they visit a patient room. We need to look at leveraging data in new ways. So there's a company called Genomic Health just down the peninsula here, and they've developed an algorithm for breast cancer patients, for a certain subset of them, estrogen, progesterone positive, non-metastatic, node-negative cancers, where they have used data to calculate what a woman's chance of survival is with surgery and appropriate medical treatment, what the chance of survival is at 10 years. And they can also tell you what the chance of that is with or without chemotherapy. Huge. It's a huge advance. So my wife is a breast cancer patient, and her score put her at the 9% chance of recurrence in 10 years, and 7% if she had chemotherapy. And she said, that's easy for me. I like to think of it as 91% chance that I'm not going to get it, and only 93% chance if I do chemo, I'm not doing chemo. What a great advance this is of using data in new ways. But we have another program, the Athena program, led by Laura Esserman, our breast surgeon at UCSF, to work across all 5 University of California medical centers and collect data on every woman coming in for breast care, before diagnosis of cancer all the way through, so that we can start to understand in more detail what distinguishes different kinds of patients and different cancers. Some cancers are so aggressive, they must be treated incredibly aggressively. Other cancers, we believe, will actually go away on their own. But we're not exactly sure up front which ones are which. And that is part of what we want to do by leveraging large population databases to start to glean some of this. And these are areas where you may be able to help us as well. And then how do we accelerate the time of discovery of a new approach to its general adoption? So James Lind here, you probably all remember him. He was an officer in the British Navy in 1747. And he did a very important test. He tried 6 different approaches to dealing with scurvy. And he learned that if you fed your sailors citrus, that they would not develop scurvy. So he made that discovery in 1747. How long did it take until the British Navy implemented the adoption of his new treatment for scurvy? 48 years. From the time of discovery until it was generally adopted, 48 years. Now, we move ahead to 2003. The Institute of Medicine did a study looking at how far we've come in the 250 plus years. It's now down to 17 years. In medicine, 17 years from the time of a general discovery until its general adoption in the healthcare industry. Well, many of you may be familiar with the work that was done by Ray Kurzweil in his 2005 book, The Singularity is Near. And he predicted that by 2045, singularity would occur. That's when computers meet or exceed human computational skills, and their computers' ability to continually improve their knowledge will lead to an intelligence explosion, with the idea that medical knowledge will flow immediately from the laboratory into clinical practice. And I don't know how the doctors fit into that or not. Well, I don't know if that's right. 2045 seems like a long way off. Seems like this is something Mark might want to announce next year, in fact, wouldn't it, at Dreamforce 3. But whether that's right or not, we know that we need to be moving and thinking about changing our healthcare industry so that it moves at a different pace in a different way to benefit people. Now let me talk about one of the lowest tech solutions there is. If I told you that for $5 you could implement an intervention that would protect a family of 4 for 4 years from a disease that kills 1.5 to 3 million people a year, you'd say, well, let's do it. But our scientific problem is not that we don't know how to do it. You see these kids have mosquito nets. But we need a way to get it done. And part of our challenge is how do we do the science of application to take what we already know and implement it. Now I'm going to go through policy issues fairly quickly. Policies really state what's important to us. And one of our challenges in the healthcare industry is we're not entirely sure what's important to us. Is it providing care to everybody? Is it getting everybody as much care as they need or want? Is it a political issue or what? So let me just give you the economics of running a hospital. If it costs our hospital $100 to provide some care, some medical care, here's the economics. Medicare pays us $95. So every Medicare patient walks in the door, I'm going to lose $5 on. Every Medi-Cal patient that walks in the door, poor patients in California, Medicaid nationally, $40 they're going to pay me. I'm going to lose $60. And then I'm hoping that I've got enough Blue Cross and Blue Shield patients. I hope nobody from Blue Cross or Blue Shield is here. I'm going to get $135 from them. And so I'm Robin Hood in Sherwood Forest. I got to get enough of those insured patients coming through to cover the cost of the lower income patients. Now that is a healthcare policy that our country has, through whatever neglect or so forth, ended up with. It is a problem. It is a real problem because the whole healthcare reform puts more patients into Medicaid, Medi-Cal, and takes them out of commercial insurance. Is healthcare a right? I mean, what do you think? Is everybody have a right to healthcare at the highest level? This debate's going on in Arizona right now where the discussion is organ transplants will not be provided to Medicaid patients in the state of Arizona. Oregon tried this several years ago, and when someone developed the need for a liver transplant in Oregon, they're very smart in Oregon. They just moved down south of the border into California and established residency in California, and then California would provide the liver transplant for that patient. It's very hard when we get to the issue of the R word, which we talk about is rationing. Now, you know, with any scarce good, there is some kind of rationing, and in healthcare, it's no different. And we feel that at some point, we're going to have a major national debate, a serious discussion about how much healthcare everyone should get as a basic right versus how much health care people should get if they're willing or able to pay for it. Now, the fact of the matter is today, if you're uninsured, you're going to struggle to get the health care coverage you need. But if we insure more people, if we insure all Americans, which would be a great thing to do, if everybody gets coverage, we'll be in a whole different place. And we are going to have to think through how we ration health care. We need unusual thinkers. We need you to be involved in this debate. How am I doing on time? Doing okay. You want to hear this, CEO's death panel. Okay, so here. You're the CEO of a university hospital. You're self-supporting. You've got to run the business. Nobody's giving you any extra money. You've got to run it. Your chief medical officer comes into you with the chief financial officer and your chief ethics officer, and they say, you need to make a decision. So you're going to make this decision. There's a man at a neighboring hospital, about 45 years old. He needs a surgical procedure. This surgical procedure will save his life if he gets it. If he doesn't get it, he won't make it. This patient, however, is a hemophiliac. And not just a normal hemophiliac, he is allergic to normal blood clotting factors. And so if this patient comes to our hospital, and your hospital, you know, could provide this surgery, if this patient comes to your hospital, you are going to have to buy from Novo Nordisk, who manufactures the hypoallergenic factor 7, you're going to have to buy $1.5 million of Novo Nordisk factor 7 to administer to this patient. Now, the patient may not make it, and that money might go down the drain. This patient, by the way, is covered by Medi-Cal. So probably you would receive at max $75,000 of reimbursement for his entire care, not just the drug, the $1.5 million, that $75,000 doesn't go very far to cover, but also for the nursing care and the surgery and everything else. So the choice is yours. Do you say, go ahead and bring this guy over, and we'll just eat it and hope for the best? Or do you make a decision to say, you know what? We can't solve all problems for all people. Every other hospital's turned this patient down. We'll turn him down too. What do you do? Anybody want to shout out an answer? Well, I'll tell you, this is the kind of issue that happens every day in hospitals. In that particular case, I made the decision. I was the death panel, except I said, go ahead and do the case. And fortunately, that patient walked out alive after 3.5 weeks. Now, it could well have been that he didn't make it, in which case we would have, that money, there would be nothing to show for that money. But he lived, although I still wonder whether it was the right thing to do. We can't afford to do that for everybody who comes into the hospital. And in fact, I worried that at some subsequent point, he was going to need another surgery, and he'd be someplace else and no one would take care of him, and that investment we had made in him would be wasted. Well, those kinds of decisions are coming up all the time, and that's why policy debates really need to be out and open. I could give you a dozen of these circumstances. We run a bariatric surgery program for morbidly obese patients. Most of them are poor. Most of them are covered by Medi-Cal. It's going to cost me $10,000 to do a surgical procedure, and I'll receive $4,000 of reimbursement. Do we do it for everybody in the order that they sign up? Do we do a couple of Medi-Cal and 10 insured patients? We've had to make that decision. And so these things are going on all the time, and I urge you to start to get involved, and we'll probably pull you in. Okay, people. I told you this is an incredibly labor-intensive industry. And one of the challenges that we have in healthcare is just communication. So if you're a patient or your parent is a patient in a hospital, well, let me ask this. How many people in this room have either personally or in your family had a medical error, been on the receiving end of a medical error in a hospital? So a fair number of people in this room. The number one reason that errors happen in hospitals, by far, is communication errors. Somebody didn't pass on a critical piece of information. So one of our innovators, our unusual thinkers at UCSF, is a guy named Bob Wachter. He's a national patient safety expert. And we have put together a proposal to find an online, in the cloud way for people to communicate, for our caregivers to communicate about the care of an individual patient. We are actually going to try using Chatter as a way to link everybody together. Has nothing to do with the Benioff naming of our children's hospital. I just want to let you know that. It really doesn't. But this is an example of how we can use technology in a different way to facilitate delivering better care. Now, Massachusetts, as you know, passed healthcare reform of their own. Everybody's insured, almost everybody's insured. What happened in Massachusetts? What happened is demand went through the roof. Medicaid patients went through the roof. The number of doctors available to care for those patients stayed the same. And so demand went up and capacity was flat or even went down. And this created a huge problem. So you have insurance, but you can't get an appointment. This problem will be on steroids when we go to national healthcare reform and bring on uninsured people into the healthcare system. There's no way to have enough caregivers for the patients who need it. Now, David Lawrence was the CEO of Kaiser Permanente. He's a primary care physician himself, a brilliant guy. And he has proposed that we scrap the whole idea of primary care. Now, I'm telling you, this is Nixon going to China. This is, it's like, whoa. David Lawrence, Kaiser, built on a primary care system. He said, scrap that. He said, we've got to distinguish the sickness system, when people are sick, from the wellness system. And we need a way to use technology to automatically feed back when a patient actually needs a health intervention, to give them real-time coaching on improving their health and avoiding that cookie, or getting up a little earlier to make sure you get the exercise in, and tracking your blood lipid levels, et cetera, et cetera, et cetera. Now, some of this is going on already for heart failure patients who every morning stand on the scale and it automatically feeds into hospitals. But we really need to take this to another level. And David Lawrence's premise is that the only way that we solve the healthcare problem long-term, that healthcare manpower problem long-term, is with more technology and more technologic innovations. And again, we turn to you to be thinking as unusual thinkers about how we might actually make that happen. My clicker. Can I have some clicking help? Or maybe am I doing it myself here? Here we go. And I just mentioned this issue of monitoring. Andy Grove, in fact, mentioned this morning, is one of the first people to talk about putting monitors in the floor under the carpet so that individuals, so elderly patients staying at home by themselves, you could actually track in and see how they're doing. And Steve Bird at Safeway, another unusual thinker, thinking about ways to lower healthcare costs by giving employees an incentive to take better care of themselves. And in fact, at Safeway, they have lowered their healthcare costs when others have had increases because of that in its entirety. So the goal is an optimally healthy society. The physical, mental well-being of everyone, as well as the economic viability of our society. We need to build a new healthcare model, a new healthcare system on the successes of the past, but we can't be captive to the past. We've got to get out of the office visit as the common denominator for how we deliver healthcare. And we need to collaborate in different ways across different industries in ways we've never thought before. UCSF and Salesforce, Chatter, to improve the quality of care for our patients. And we all need to be unusual thinkers. Well, as I always do, I always end with this quote from Mark. I don't think we've usually had his picture up here quite as graphically as this. But I think this is a very important point, that we do tend to overestimate what we can do in 1 year, but we don't recognize our potential over the long term. I think this decade will be the critical decade of change. This is the inflection point in healthcare, and I hope all of you unusual thinkers will join us as we try to define a better healthcare future for our country. Thank you very much.